and try to spotlight initially me and then Dr. Bhaskar and then go to the review. Yeah, I'll just change the setting. Dr. George sir ochara okkar chudandi. Azar, make Dr. Suchitra also co-host.
So, Dr. George, half an hour untananna sir.
Okay. Ade, endukante settings will be changing so that only the co-host can speak.
Yeah.
Yeah, I think we're all set. Welcome, Dr. Suchitra.
Yeah, good morning, Dr. Good morning, sir.
Good
morning, Tilak sir.
Good morning.
Good morning, sir. Good morning, sir.
It's 9 o'clock, so we'll just begin. I'll just change the settings.
Dr. Suchitra, Dr. George is not coming.
Sir is coming, sir. Sir,
Okay.
sir said he'll join. I was just waiting for him. I'll just check on once again, sir.
He was in actually.
Yes, sir.
He was
In
in
like it
and
called
then
you, sir.
Right. President sir, can we begin?
Shall we wait 1 minute for Dr. George?
Okay.
Just 1 minute.
Sir, George sir has joined, I think, sir.
Azar, please make Dr. Jane George as co-host and then we can begin.
Okay, ma.
Yeah, thank you.
Yeah, good morning, Dr. George Garu.
Amma, good morning, ma. Bhaskar garu.
Morning, George sir.
Baya, morning.
Good morning, sir.
Amma, morning.
Yeah,
Bhaskar is smart.
Indoor smartness. Indoor.
Oh, great. Ye marla Bhaskar bhai. Vijay Kumar sir, good morning.
Good morning, sir.
Tilak sir ikkada ravali.
Good morning, George, sir.
Yeah, good morning.
RSV?
అయ్యా భాస్కర్ ఇప్పుడు అజయ్ మోహన్ ఇప్పుడు మీ వాడు కాదు మావాడు. జాగ్రత్త.
అయ్యో అజయ్ రానన్నాడండి, మీరు చెప్పబట్టి వచ్చాడు అజయ్.
అంతే
ఇది వెరీ ఫ్రాంక్.
అదే
అంటే యాక్చువల్లీ వాజ్ ఆక్యుపైడ్ విత్ వెరీ ఇంపార్టెంట్ ఫంక్షన్.
అవునవును, పాపం ఏదో వర్క్ ఉంది, ఒక అరగంట చూడయ్యా అంటే పాపం రిక్వెస్ట్ చేస్తే వచ్చాడు.
మరి మీరు చెప్పారు కాబట్టి ఎనీవే థ్యాంక్స్ ఫర్ బోత్ ఆఫ్ యూ.
Sir, can we begin?
Yeah, please.
Yeah, 1 second, sir. I'll just change the setting.
Tilak sir, good morning, sir.
Good morning, everyone, and welcome to Indian Academy of Pediatrics Twin Cities branch postgraduate clinics. And it's a pleasure for us at the Executive Board of IAP Twin Cities branch to host all of you for an exciting discussion on a very interesting case with experts in the field of medical education. PG clinics is a wonderful time even for practitioners to look at these complex cases which we otherwise may not experience on a daily basis. But this is what gives us that joy and that excitement of practicing pediatrics in the OP setting as well. So I hope we'll have a wonderful time enjoying the discussions on not just the case alone, but also on the approach of the case, on how we come to the diagnosis and more importance given to analysis of the symptoms. I welcome all the experts today, Tilak sir, George sir, Dr. Ajay Mohan, and all the experts and Dr. Vijay Kumar sir and all the experts who have joined us. Please feel free to type in the chat box. The discussion will be more fruitful and also enlightening for all of us if we can all participate. I now request our president, Dr. Sunkoj Bhaskar sir, to give his presidential remarks, and then we can quickly begin with the case. Over to you, Dr. Bhaskar sir.
Yeah, thank you, Dr. RSV. Thank you. Respected seniors, distinguished faculty members, Dr. Tilak Chandrapal, Dr. Vijay Kumar, Dr. George, Dr. Ajay Kumar, Dr. Suchitra, presenter Dr. Fatima, Juveria Fatima, dear colleagues, ladies and gentlemen, welcome you all to this second symposium on PG clinics. Last time we had a huge response of more than 350 persons on Zoom and YouTube. And it was really encouraging to the organizers, that is IAPTCB executive body. And today morning when I was talking to our Dr. Raghav, whom we all call the Chanakya of Indian Academy of Pediatrics, Twin Cities branch, and as well then Andhra Pradesh state. So he was telling me during his days when he was an assistant during 80s, and then when he was professor during 80s and 90s, he was saying the students were hardly being taught by the concerned ward assistants, assistant professors, associate professors, and the unit head. And really, compared to those times, now he says there are so many academic activities being done by IAP, particularly IAPTCB, Twin Cities branch, Telangana state, and as well many other states. He says that if a postgraduate attends these meetings regularly and follows it seriously, I think that is enough for him to get through the pediatrics postgraduate final exam. So this was really very interesting to me. I believe, I am sure all of you agree, so much of academic experience is reaching to you, to your homes. Therefore, I request all the postgraduate students, you are so lucky, please make use of all these academic activities which are coming online and sometimes in person. Not only them, people like me practicing pediatricians, I think we should participate, and me personally, I'm learning a lot. And this particular PG clinics, history making, physical examinations, they are taking me to the 90% of the clinical case diagnosis. Hardly 8 to 10% I will go for investigations and cross reference from experts like you people and some subspecialists. So this is so much important. And we at IAP TCB executive body, we are committed to present you entire 12 IAP TCB PG clinics, 12 IAP TCB clinical meetings, and 12 IAP TCB symposia. Make use of them, participate in a big number. That gives encouragement to our IAP TCB, our experts. For example, today, Dr. Tilak Chandrapal sir, Dr. Vijay Kumar from Warangal, despite their busy schedules, they had immediately accepted, including our professor, Dr. George, who is really busy every day and particularly on Sundays. Despite that, he had attended. Dr. Vijay Kumar, though he had an important family function, he is attending. These people, see, they have that zeal and enthusiasm to spread their knowledge and skills to the coming up generations. That is none other than you people. So my salutes and thanks to the experts who had readily accepted, and special thanks to Dr. Suchitra, who is the key person
మన పీజీలందరినీ జాయిన్ అవ్వమని చెప్పు.
who had motivated others, and she brought the long case from Gandhi. Once again, my special thanks to the case senders, faculty members, and the presenter. I'm sure you know the biggest beneficiary of this IAPTCB PG clinic is none other than our presenter, Dr. Juveria Fatima. It simulates the experience of your final year exam of your MD Pediatrics. You are a lucky student.
Thank
so
you.
Lastly, wishing you all a great learning experience and long live IAP. Jai Hind. And over to Dr. RSV.
Thank you, sir. I now hand it over to Dr. Tilak Chandrapal and Dr. Vijay Kumar, sir, to please introduce the topic, and then Dr. Juveria to take over from there. Vijay Kumar, sir, please.
సార్ మాట్లాడుతున్నారు తిలక్ సార్ తిలక్ సార్
Yeah, welcome all of you. This is a second case presentation in the IAPTCB. I hope all of you will get benefited by the presentation. And we try to discuss as the case go by. Of course, it is a gastroenterology case that is being presented. With this, I hand over to Dr. Vijay Kumar.
Tilak sir, good morning.
Good morning, sir.
Good morning, Dr. Bhaskar sir, Dr. RSV Krishna, for giving the chance to participate and share what. Dr. Juveria, this is not your final year examination as such, it can be a rehearsal. You have seen the case, your unit has worked up this case. You present the case to all of us. We can discuss and go through for similar cases in future, how to improve or how to, this is knowledge sharing.
Yes.
Yes, I think, sir, Tilak sir, over to Juveria sir to start presentation. Yes.
Dr. Jar sir, would you like to make some comments?
Okay. Good morning to all of you. So I thank the IAP, mostly the president and also secretary, Dr. Bhaskar sir and Dr. RSV. They are very much keen in conducting all the academic activity. I am very much thankful to you. And even the PGs are getting a lot of benefit by this. And we are also learning a lot. So this is a platform. IAP is now became an academic platform for learning purpose. Thank you. Now we would like to start the case.
Thank you, sir. Shall we ask Dr. Juveria to present the case?
Yes. Good morning, everyone. I'm Dr. Juveria from Gandhi Hospital, Pediatrics PG. Thank you for giving me an opportunity for this case presentation. A 4-year-old male child by name Hasrik, resident of Hosurabad, was brought by reliable informant mother with chief complaints of vomitings 5 days ago, yellowish discoloration of eyes since 2 days, excessive sleepiness and irritability 2 days ago, altered sensorium and not responding since 1 day. Child was apparently well 5 days ago, then he developed vomiting for 2 days. There were 2 to 3 episodes per day, non-bilious vomitings, non-projectile, content was digested food and water, not bloodstained, not associated with pain abdomen. Then the mother noticed yellowish discoloration of eyes since 2 days, which was static, non-progressing. On the same day, mother also noticed high-colored urine, history of 1 episode of melena the same day. The child had excessive sleepiness 2 days ago. He was irritable when aroused from sleep. Then next day, he developed irrelevant talking. Later, his sensorium deteriorated and he was not responding to mother's call. There is no history of fever. There is no history of clay-colored stools. There is no history of itching in the body. There is no history of blood in urine. There is no history of any other bleeds in the body. No history of abdominal distension. There is no history of joint pains or rash over body. There is no history of seizures. No history of headache prior to onset of symptoms. No history of inability to use limbs or any paucity of limb movements. No history of head trauma. Past history. Child is a known case of seizure disorder diagnosed at 1 year of age, for which he was using sodium valproate since 3 years, and he was in regular follow-up with his primary.
Just a minute, Dr. Juveria.
Yes.
Till present history, till present history so far, the positive history, try to analyze the symptoms. Just explain the symptoms, what you thought at this point.
Sir, the child had vomiting, sir, initial presentation. That is not associated with any abdominal discomfort or any abdominal symptoms. The child had, there is no history of fever, sir. So we could attribute this vomiting to any other cause. It could be any metabolic derangement or it could be any central cause of vomiting. And then there is also mother noticed yellowish discoloration of eye since 2 days, sir. That means there is jaundice in this child and there is high colored urine, sir. So we can attribute it to hepatocellular jaundice. And there is no history of clay colored stool. So it is not obstructive jaundice, sir. And there are bleeding manifestations. So the child has deranged coagulation also, sir.
So
And
why metabolic initially? So anybody will think of viral hepatitis initially, is it not?
yes, sir. Viral hepatitis, but there's no fever, sir, in this case.
No, fever, even anecdotal hepatitis can come, is it not? Sometimes.
Yes, sir.
So with manifestations. Moreover, you presented it as melena, but
Yes.
no patient will complain melena. Will they tell melena?
Black color stools.
Black, you
Tarry
have to
stools.
further qualify it. Just black color is not enough.
Black.
If you take
tarry
iron also, it will be black. If constipation is there, it will be black.
There is no history of constipation.
No constipation, but here what I have to tell, the black tar is too.
Tarry stools.
Like a pouring molten tar. That is
Yes.
melena. So that description you have to give, but not melena. Melena is your finding, not their finding. What they say is it is like a tar and flowing.
Yes.
Description will be like that. Okay. Yeah. Dr. Vijay.
At this point, this is an acute case.
Yes.
So the longest duration, the first symptom is vomiting, which is 5 days.
Right.
And within 5 days, the child has quite serious symptoms.
Yes.
And you said there is no history of fever and no history of convulsions.
Yes, sir. No history of convulsion.
No history of convulsion, no history of fever also, you say.
Yes.
Nobody recorded at home. On this, with this 5 days to 6 days history, which is quite short, and it's a stormy case, how many systems are involved at this point? Let us not go into the diagnostics of which jaundice and all that. At this point, how many systems are involved?
Sir, gastrointestinal system and central nervous system.
Yes. Which is leading to the other? We can go further.
Yes.
Which system has it started with gastric system, or the primary CNS disease or primary gastrointestinal or liver disorder? We'll go further. At this point of time, there are 2 systems involved and the child is quite sick and it's an acute case.
Yes.
Right? Thank you. Carry on.
So valproate, what days she is getting?
He was using in appropriate doses, sir, 30 mg per kg per day.
30 mg per kg per day. Okay. So valproate will cause jaundice?
Yes, sir. It can cause drug talk. It's an hepatotoxic drug.
It is hepatotoxic, but will it cause jaundice?
No.
Because it mainly affects the mitochondria, no?
My hepatopathy is like Alpers syndrome. It can.
So there won't be jaundice. So here the valproate may not be the responsible thing.
Yes.
How long is taking this valproate?
Since 3 years.
3 years. But valproate can be one of the precipitating causes for some other etiology like that. Okay. Right.
Past history, child is a known case of seizure disorder diagnosed at 1 year of age, for which he was using sodium valproate since 3 years, and he was in regular follow-up with the primary physician. History of jaundice and vomitings 3 months ago, which subsided in 10 days with medical treatment, and he was advised to stop anti-epileptic drug. He was not on any anti-epileptic drug since then. There is no history of blood transfusion. Family history is born out of non-consanguineous marriage, first in birth order, no history of contact with a jaundice patient, no history of TB contact. His antenatal history: first, mother is a registered antenatal case, had regular antenatal checkups, took iron and folic acid supplementation in TT doses, no history of hypertension or diabetes, fever with rash in mother, no history of blood transfusions. His natal history: full term, he was born out of an institutional normal delivery. His birth weight was 3 kgs. He cried immediately after birth, breastfed within half an hour of delivery, no history of NICU admission. His postnatal history: was exclusively breastfed for 6 months, after which complementary feeding was started. He was breastfed up to 18 months of age. Developmental history: attained all milestones appropriate for age. Immunized up to 2 years of age as per national immunization schedule. Takes both vegetarian and non-vegetarian food. By 24-hour recall method, he has a deficit of only 100 kilocalories and proteins of 2 grams per day. Socioeconomic history: he lives in a pakka house, adequately ventilated, 3 rooms, kitchen and toilet. There are total 4 members, no overcrowding, proper sanitation facilities available, access to safe water is there. He belongs to lower middle class according to modified Kuppuswamy scale. So at admission, on general examination, child had a Glasgow coma scale of 8/15, sir. His and vitals: his temperature was normal, pulse rate was 130 per minute, regular, low volume, respiratory rate was 42 per minute, abdominothoracic with bilateral intercostal retractions. BP was 70/50, which was hypotension less than 5th centile for his age, in left upper limb in supine position. Saturation and room air was 89%, with high flow nasal cannula was 95%. His anthropometry: his weight and height were within the 58 to 95, 97 centiles. Sir. His head circumference was normal for his age group, and mid upper arm circumference was 13 centimeter. Upper segment and lower segment ratio was normal for his age group. Head to toe examination: head appeared normal in shape and size.
1 minute. If the child comes with hypotension and Glasgow coma scale of 8/15, you will be seeing all these things?
No, sir. Late.
Then what you will do?
Yes. We'll first manage the emergencies.
Yeah, like that.
In the primary assessment, it is the primary assessment of the trial. You will resuscitate the child.
Yes.
So while you started your resuscitation, you'll try to think whether it is encephalopathy or encephalitis.
Yes.
While you started your resuscitation.
Resuscitation. Yes.
After even all these findings are after resuscitation.
Yes, sir. His anthropometry is after resuscitation.
Right,
But-
right.
Doctor, please discuss after the initial resuscitation, encephalitis versus encephalopathy.
Encephalitis, sir. There was no history of any seizures in the child, sir.
Right.
And there is altered sensorium, sir. His sensorium, he was only responding to pain stimulus.
Fever?
There is no fever, sir, at presentation.
What are the other history you ask for encephalitis? Whether he comes from an endemic area or not.
Endemic area.
That's
Yes.
also one. For encephalopathy,
Any fever can cause encephalopathy, sir. Any metabolic derangements can cause encephalopathy. They can be hypertension, hypertensive encephalopathy. Sir.
encephalopathy is predominantly fever may or may not be there.
May not be.
The encephalitis, there will be changes in the CSF.
Yes.
The encephalopathy will be waxing and waning.
Yes.
No?
Okay.
Okay.
So shall we proceed further, sir?
Shall we?
No,
Okay,
just
next.
a minute, sir. In case you think it is encephalitis versus encephalopathy, with a point slightly towards encephalopathy, what are all the infective organisms you will think at this point? Right. This is a case which is going, which may go to any side, but you are in your emergency room and in the initial hours of management.
Yes.
What are all the infections you will think at this point?
In encephalopathy, so we can consider any dengue fever, sir.
Right?
And malaria also we can
Yes,
consider.
good.
And leptospirosis also we can consider.
Carry on.
Leptospirosis.
Yes.
Oh, come on, carry on.
His head-to-toe examination. Head appears normal in shape and size. There is icterus, there is pallor. There is no cyanosis, no clubbing, lymphadenopathy, and edema. Ears and nose are normal. Posture, child is lying supine on bed with arms adducted. Oral cavity is normal. No skin rash, no petechia or purpura, no scratch marks on body, no palmar erythema or spider navel, no joint swellings. His external genitalia appear normal. Systemic examination. The gastrointestinal system was examined. Child was examined in supine position. On inspection, abdomen is not distended, flanks are free. Umbilicus is normal in position and inverted. Skin over abdomen is normal. All quadrants are moving equally with respiration. No visible veins, scars, and no visible peristalsis. His hernial orifices are free. External genitalia are normal. On palpation, there is no local rise of temperature, no tenderness. Abdominal girth is 46 centimeter. Liver is palpable in the right hypochondrium, 4 centimeters below the right costal margin and mid-clavicular line. It moves with respiration. It's non-tender, soft in consistency, smooth surface, round borders. Spleen is not palpable.
1 minute, doctor. What is this local rise of temperature?
Is there any abscesses in the body and can
But it
produce?
is swelling. Or a mass,
No, sir, there's no.
parietal mass. So then this local rise won't pertinent. Is not pertinent. No.
Okay, sir.
If you see a parietal swelling, you can see whether it is a cold abscess or hot abscess. No.
Okay.
So otherwise, or a hemangioma is there. Okay, you felt the
Hemangioma.
it is warmth. Otherwise, this without anything local rise of temperature, I don't think it is pertinent.
Okay.
All right.
Two more.
The spleen is not palpable. On percussion, there is no evidence of free fluid. Liver span is 10 centimeters. Auscultation, bowel sounds were heard. There is no bruit. His central nervous system.
For completion's sake, what are the two more points in the liver palpation that you should answer definitely? One is you said.
We should also see whether the
surface. This is quite acute case. This is an acute case. Are you hearing me, Emma? Hello? Am I audible? Hello?
Yes, sir.
Yeah.
Yes, sir. You are audible.
What are the 2 points in the liver palpation or the details in the liver you see? Surface of the liver?
Surface is smooth, sir.
Surface.
Soft in consistency. It is not.
Right. What are the other things you see in surface?
Any nodularity.
Edge also.
Edge.
And also hepatojugular reflex.
Okay.
No.
Okay.
So this gives lot of information. No?
Surface smooth. Upper border you should see. Palpation. With a percussion. Sorry. It is in percussion. Yeah.
Okay. His CNS system was also examined, sir. Higher mental function, the Glasgow-Coma scale was 8/15, sir. Cranial nerves, pupillary reflex was present. Both the pupils were dilated. Corneal reflex could not be elicited. Gag reflex was present. Doll's eye reflex was present. Motor system, his bulk was normal. Tone, there was increased tone in all the limbs, both upper limb and lower limb, and flexor and both flexion and extension. Power, the child withdraws to pain in response to pain and moves all limbs equally with no apparent deficit. Reflexes, his biceps was 3+, sir. Triceps was 2+, knee 3+, and ankle 3+. Superficial reflexes, abdominal reflexes were present, and plantars were extensive. His sensory system, child response to pain, cerebellar signs were not elicitable, no signs of meningeal irritation, spine and skull was normal, fundus showed papilledema. Other system examination, respiratory system, trachea appears central, bilaterally.
Just a minute. Papilledema, any details?
Yes, sir.
If you have, you give. Otherwise, no.
No,
issue.
no.
Usually, the history that was given was 5 days or less than a week. No.
Yes, sir. 5 days. Yes.
Why papilledema happens? What is the usual duration of papilledema happens?
Acutely, it can be in hypertensive encephalopathy, sir. And any raised ICT symptoms can produce acute papilledema.
Usually, what is the duration? Is it as early as 5 days, 7 days?
No, sir. After 2 weeks.
Right. Any posturing in this case when you received the child, abnormal postures?
Posturing was not there, sir, but tone was increased, sir.
Hypertonia, hyperreflexia, you elicited well.
Yes,
But
sir.
whether there were any abnormal posturing?
Posturing was not.
Right. Carry on.
His respiratory system was trachea appears central, chest was bilaterally symmetrical. All areas were moving equally with respiration. Skin over the chest is normal. His palpation apex was felt in the left fifth intercostal space, just medial to midclavicular line. All lung fields were resonant. Auscultation, normal vesicular breath sounds were present. Crepitations were present. Right. Cardiovascular system, apex felt in left fifth intercostal space, just medial to midclavicular line. First and second heart sounds were heard. There were no murmurs, no raised JVP. So summary is a 4-year-old male child presented with vomiting for 2 days, 5 days back, then jaundice and altered sensorium since 2 days, with history of 1 episode of melena, with past history of jaundice 3 months ago, after which he stopped using anti-epileptic drugs. At admission, child presented in shock. On examination, he has icterus, pallor, and hepatomegaly, with a GCS of 8/15 with increased tone in all limbs, dilated pupils reacting to light, and exaggerated tape tendon reflexes.
Okay.
Yeah.
So what are the possibilities you thought?
Sir, we first thought it could be hepatic encephalopathy, sir.
Due to?
Due to some acute cause, sir. It could be infective, but there was no fever, sir. Then we also considered it as in the ongoing pandemic season, presenting with shock and altered sensorium with multisystem involvement, also considered MISC, sir, in this child. It could be an because of past history of jaundice previously, which subsided in 10 days. It could be drug induced also, sir, with an acute insult this time. Or it could be any chronic disease with an acute insult. It can also be autoimmune disease, autoimmune hepatitis also is thought, sir, later in the course, but not at present.
Okay. In that order you thought?
Yes, sir.
First infections.
First, we thought, sir.
Yeah,
Second, drug induced.
Okay. Which drug?
Sodium valproate, but he was not using. So
yeah, it is not associated with jaundice.
Yes,
so
sir.
Rayleigh syndrome and valproate, they are not associated with jaundice.
Yes, sir.
They affect the mitochondrial function.
Yes, sir.
That I'm telling. Yeah, but it can be, the altered sensorium can be due to hypoglycemia, all those things.
Hypoglycemia. Yes.
Yeah. What about the kidney, renal function?
His urine output was adequate, sir.
Good. Okay. So to think of
are there?
Yeah. Proceed.
Sir. Are there any suggestions by history or examination so far of any chronic disease? There was convulsion at 1 year, as far as the nervous system is concerned, there was convulsion at 1 year of age.
Yes.
Now there is encephalopathy, oblique encephalitis now.
Yes.
So,
yes,
and then any chronic disease, what are the points, either in history or examination?
Chronic pointers could be his history of seizures, one. And
Right, in liver disease, because there is jaundice for liver disease. Are there any pointers to a chronic liver disease from history or from examination so far?
No.
Or what are the symptoms or signs of chronic liver disease in a child, in a 4-year child?
Yes, sir. There can be behavioral changes, sir, initially. In Wilson's disease, there can be poor scholastic performance or any behavioral changes in the child, sir. And there is no abdominal distension, sir. A chronic liver disease can present with ascites, sir. That presentation is not there in this child. And that we can.
On examination?
On examination, there are no signs of chronic liver cell failure. Signs are like spider nevi or palmar erythema. Alopecia is not there in this child, sir. And asterixis was also not there, sir. And
2 episodes of jaundice is there, no?
Yes, sir. 1 episode in the past, sir. This is the second time.
Any signs of portal hypertension?
No signs, sir. No caput medicine. No. No signs. No splenomegaly also.
Infrared light may detect sometimes. It need not be always visible. No?
Yes. Yes.
So
no spleen also, sir.
melena is there.
Yes.
So that is also a sign of portal hypertension, bleeding varices. No?
Yes.
Spleen may not be there. Once there is bleeding, a spleen may disappear.
Okay.
Ascites, you didn't see the knee chest position to see any fluid.
Yeah,
of course, condition of the child is such that you may not examine all these things.
Yes,
but these are the things which will show chronic liver disease. Signs of portal hypertension, signs of liver cell failure. Jaundice is one of the signs of liver cell failure. Encephalopathy is a sign of liver cell failure.
Yes. Fetal hepatic.
Yeah, that also the peculiar fruity odor of ammonia.
Yes. Parotid swellings.
That is, yeah. If it is a bigger child, gonadal hypertrophy, gynecomastia, so many.
Testicular atrophy. Yes.
Yeah. So many things will be there. None of them are there.
No, sir, they are not.
So it is a acute liver cell failure.
Yes, sir, acute liver cell.
So acute liver cell failure means failure within how many days you call it acute?
Less than 8 weeks, sir.
8 weeks. Okay. So how much blood is required to produce melena?
50 to 100 ml blood, sir, and it should stay for around 6 to 8 hours in the GI tract to produce.
Is it going to cause a shock?
Massive can cause shocks, sir.
Yeah.
More than 500 ml can cause shock.
Yep. So any vitamin K was given at that time?
Yes.
Did it correct bleeding?
He was given vitamin K, and we also transfused FFP in this child.
Yeah. So with vitamin K, there is any correction? No.
He got corrected after almost 3-4 days, sir.
Okay.
So the differential diagnosis is not a long one, it's a high encephalopathy, hepatic encephalopathy and
acute hepatic failures.
Right, acute liver cell failure and then hepatic encephalopathy.
Yes, sir.
And cerebral edema also.
Yes, sir, cerebral edema.
Yeah.
Yes, sir. Shall I proceed, sir?
Okay.
So this was our provisional diagnosis: acute hepatic failure with stage 3 hepatic encephalopathy. We considered the probable etiologies to be MISC, drug-induced hepatitis, autoimmune hepatitis.
Whether you consider race at this time, it's rare now.
It is very rare, but there is no history of fever and no history of any drug use by the parents in that 1 week.
Race like
that is fevers, they'll use, but it is very rare, sir. Like illnesses this time.
No, is there any evidence of COVID previously?
Previously, it is not there, sir. But presently, he presented in this pandemic time recent, sir, 1 month back. So he came COVID positives.
But at the time also jaundice is there, no?
3 months ago, jaundice is there, sir. That time he's not COVID. No history of COVID contact also.
Okay. So MSc, you consider only when there is say evidence of COVID previously, no?
Yes.
Or missed COVID?
Missed COVID.
Okay. Proceed.
So on day 1 of presentation, he was having NSCBP anemia. Blood HB was 7.6. Platelet was 45,000. He had deranged liver function test. His enzymes were elevated. Total proteins were normal. TSB was 12.9, sir. Direct fraction was elevated. His INR was, PT-INR was deranged, grossly deranged. His renal parameters remained unaltered during the course, sir. And his electrolytes and ABG was always normal. His LDH was elevated initially, mildly elevated. Then serum ferritin was normal. Serum ammonia was raised 99 at presentation. His COE was normal. His infective profile was all negative except like COVID-19 RT-PCR positive and parvovirus B19 was equivocal. His at this point we considered it to be MISC or non-infective cause, sir. We had also worked him up for Wilson's disease. That was also negative, thinking an acute on chronic presentation, sir. And after all that came negative, we considered doing ANA profile in this child, sir. Everything was negative except anti-mitochondrial antibodies, M2 positive, sir, double positive in this child.
Previous slide. You have worked up the case and you are thinking quite well regarding this case.
Yes,
of the list of this, if you select which test you will select, there is a profile, we send a sample and we get a report in 2-3 days. There are so many labs now.
Yes, sir.
Not this one, the next slide. Depending on your history and your previous investigations and clinical course, do you do all these tests or you select 1 or 2 if you have choice?
In ANA profiles.
In this, what you are expecting actually? There is something called pre-test probability, no? You are dealing this case for last 5-7 days. There is some improvement over 2 weeks. There is some improvement in liver enzymes.
Yes, sir.
And clinical improvement, you can say later. And will you do all these tests or what you are seeing for actually in this 10-12 tests?
The clinical improvement started after intervening with specific drugs, sir. So previously the investigations were done just prior to that intervention. So these are the investigations.
Previous investigations were done prior to the intervention, sir. This was done after the intervention.
How did you exclude this Wilson's disease?
Sir, we got done serum ceruloplasmin levels, sir.
What clinical, you tell me first clinical and next investigation.
On slit lamp examination, there was no KF ring, sir.
Clinical, you can do slit lamp is later. First is the KF ring. Did you exclude?
Yes, sir, there is no KF ring.
Oh. Then how does hepatic Wilson present? How the CNS Wilson present? And what are the ages?
No, in acute decompensation, ceruloplasmin may not rise.
May not rise.
Yeah.
Sir, Neurological symptoms appear later in life, sir. It is not
Okay.
early presentation. Hepatic is earlier presentation in
So,
age group.
do you mean to say, is it hepatic or CNS? If at all, it presents
Yes.
as Wilson's.
It is hepatic, sir.
If it is hepatic, what are the clinical and your investigatory findings? As Tilak sir rightly said, in acute phase, there may not be ceruloplasmin involvement, right?
Yes, sir. It can present as a hepatic failure, sir. Acute hepatic failure.
What are the other manifestations of Wilson's clinically?
It can present as autoimmune hemolytic anemia, sir.
Yes, okay.
Present as a case of isolated hematuria, or it can
Okay.
also present like rickets-like presentation.
Copper accumulation, fine.
Yes.
See, okay. So you said also there is anemia also, jaundice and anemia.
Anemia.
Can you say Wilson's overall, hepatic Wilson's?
It can.
Right. Sir, continue. Tilak sir.
Yeah. Any involuntary movements in this child you mentioned?
No, sir. No involuntary.
No involuntary. Hysterexis?
Not there, sir.
Not there. So this child was intubated?
Yes, sir. Mechanically intubated. He was intubated and he was managed like an acute liver failure, sir, with FFP transfusion, vitamin K.
But what is suggested of MISC here?
Only evidence of COVID positivity we can say, and multi-system involvement, deranged coagulation, sir.
That is long back, at least 3 weeks gap should be there, na? After positivity.
Sir, as per WHO, any child with more than 3 days history of fever, 0 to 19 years, and the criteria are there, sir.
But you told there is no fever also.
No fever, sir, in this child.
Yeah.
But we had, and in the presence of serological evidence of COVID positivity, we can consider. Yes, sir.
Because myocardium is the one which is going to be affected mainly in children.
Yes, sir. 2D echo was done later, sir. It was normal. After
Anything in that?
many days after stabilization, after 2 weeks, it was done, sir.
Anything in that?
Normal it came. 2D echoes.
No, there is one more. You have done RT-PCR or COVID antibodies?
Sir, COVID RT-PCR positive.
Yes, and have you done COVID antibodies? What is the diagnostic criteria of MIS-C? It is COVID RT-PCR positive. The child right now has viremia.
Yes, sir.
Then how it is MIS-C? It is COVID, complicated COVID, no? If
Yes,
you want to consider this one, in a pandemic situation, how much which was on which day? COVID RT-PCR positive?
At the day of admission.
On the day of admission. And whether this is totally causative or not, we do not know. But how, and what were the COVID antibodies level later? Then that should tell us about MIS-C, no? And of the antibodies, which antibody?
IgM, COVID IgM. But we could not get it done, sir. COVID IgM antibody. We don't have.
COVID IgM was done?
No, sir.
Right.
We don't have that facility.
Antibodies, I think they're not.
Let us be very clear about COVID. In a pandemic situation, if whoever are sitting in this room, if we do an RT-PCR, we don't know, there will be surprises on the asymptomatic. Whether this COVID RT-PCR, how much RT-PCR is contributing to the clinical picture, really we do not know.
Yes.
And such cases in your unit and other units, that we can have a case series like thing. To say MIS-C, I thought we must do antibodies, COVID antibodies.
Yes.
Even that in a pandemic situation, it is to decide on causation, it would be difficult. What are the other things you would consider other than MIS-C?
Any other metabolic disorders you thought of?
Yes, sir.
Apart from Wilson's, any other metabolic disorders you thought of?
Mitochondrial hepatopathy, sir, but
Race syndrome.
syndrome.
Can you consider race syndrome?
Jaundice won't be there. Hepatorenal syndrome. No?
Hepatorenal.
Mainly.
It's
And
not
So,
this was normal.
not of any galactosemia, fructose intolerance,
but the age group is
no,
not there, so we
tyrosinemia.
Consanguinity was not there in the history.
not there.
That doesn't rule out a metabolic disorder. There are 2 episodes of jaundice also, but because this is a caste-based marriages, no? It need not be a consanguineous marriage. Caste-based marriage is always you have to consider almost like a consanguineous marriage.
Yes, so we got his urine for reducing substances, and that was negative. So.
Amma, what are your points going towards the autoimmune hepatitis? How does it clinically and how does it clinically present, and what is your points towards autoimmune? Why do you think about that?
Sir, autoimmune can present like acute presentation, sir. It can have an acute viral illness like presentation. It can also present like an acute on chronic presentation over a period of few weeks or more. And we also considered in him because he had promptly responded to steroids in the course of our treatment, sir.
Okay, fine.
And
Fine. Vijay Kumar sir, Tilak sir.
he never had his globulin levels were always in total protein, sir. His globulin level were always normal, sir.
Okay,
Albumin
fine.
and globulin.
You said some leptospira, and what is your exclusion or inclusion of leptospira?
Any conjunctival congestion you found in this slide? Conjunctival congestion for MISC or leptospira or Kawasaki, whatever it is.
No, sir, there was no conjunctival
Congestion or the non-purulent conjunctivitis, anything like that? Not there.
Not.
How is this child today, and he is discharged or with you now?
He is discharged, sir.
And at discharge, what was his condition?
His stable, sir. His sensorium is good. He's playing like normal children, and his icterus has also subsided at discharge.
So okay, with steroids, we felt that there is a bit of improvement.
Yes.
And others. Huh? Okay, right. So can we also consider autoimmune disease in this case?
Yes, sir. But
yes. I would like to ask the experts also. Sir, can we also consider the autoimmune hepatitis with this? MISC is one.
Immunoglobulins, yes. Because all the ANA profile is normal.
Sir.
And also immunoglobulins didn't raise, that's what telling us. Globulins are normal.
No, some antibodies came positive, sir.
Anti-mitochondrial antibody
Mitochondrial antibodies came positive, sir.
Okay.
Repeated this.
We have investigated thoroughly. Because they are positive, we also had a opinion in our mind that we'll consider autoimmune, and that's why we started steroids.
So, the autoimmune hepatitis you have to exclude. So before giving steroids.
Yes, sir.
Yes,
before
sir.
starting steroids, we have to confirm with that.
Yeah, the antibodies are positive, sir, mitochondrial. That's why.
Okay.
Sir, so this is also another one. So this case was presentation was very strange, sir. So that's why we thought because in this COVID season it can be still MISC or it is autoimmune. There is no fever at any time. So we thought it's a good case to present because we'll get a lot of discussion.
Right.
Vijay Kumar, sir, what do you say, sir?
This is actually an acute liver cell failure with encephalopathy, or a second chance is there is a recurrence because there is one episode of jaundice previously. Maybe it's a second episode of jaundice, and for a while the valvular and the convulsions will not consider.
Yes,
that way there is autoimmune Tilak sir said hyper the immunoglobulin profile, I think before starting steroid, if not liver biopsy, immunoglobulin profile, I thought that would have helped, sir. And platelets were platelet counts, they were never low.
They were low, sir. They
They
were.
were low, sir. They were low, sir. Platelets also low. Anemia is there.
Right.
The arrow mark is the point where we had started steroids in him after ruling out all infections and
Coombs
also
test amma, Coombs test ayinda.
Coombs test was also negative, sir, for them.
Right.
Okay.
Sir. Okay.
And always the direct fraction was more than the indirect fractions are in him. And we had only ammonia was elevated and antimitochondrial antibody M2 positive, sir. There are studies only 5 to 20% of cases can have AMA2 positive.
Okay.
And if it is there, it can be an overlap syndrome in the future. The child can develop primary biliary cholangitis. That workup is still pending in this child, sir. We have to go.
That's overlap syndrome.
Yes, sir.
Yeah. So
Actually, before starting the valproate, they should have done a baseline LFT.
yes.
So last time when he had jaundice, they could, wherever they went, only total serum bilirubin was done, sir. His full profile was not done, sir.
Bilirubin won't rise now.
So to add one point, sir, to add one point at this stage, autoimmune hepatitis in few of the cases, in mostly 20% of the cases, the autoimmune profile may be still be negative and they may get positive over the course of the disease. However, one or two pointers that may help in clinching the diagnosis is autoimmune hepatitis was there in this case, and that is the reason they have started steroids for this child.
Yeah.
So a relapsing hepatitis with overlapping syndrome later with some auto antibodies positive. Still we are in the diagnosis of autoimmune hepatitis and we'll follow it, sir. We'll follow it with immunoglobulins and others.
Right.
And one point was, this is not related but important in our day-to-day this thing. When this child, this is 4 years child at 1 year of age, it was a seizure disorder and valparin started and was continued for 3 years. This I thought we all of us should think.
Yeah.
And the diagnosis was a seizure disorder. And maybe in the previous records we can check what could be the indication of valparin that was given for 3 years.
Yeah.
They never had a record of EEG or any imaging, sir.
That's what.
It was an unprovoked seizure as per the history, sir, as per mother's history.
No, it is not you who have done that, no? But it was done 3 years back somewhere else. Yes, this usually happens. Most of us see such thing. And what could be the indication of valparin, which was given for 3 years?
Actually, first seizure you don't start, no?
Sir.
Isolated seizure you don't start. Maybe
Yes.
Second seizure.
Yes, sir.
No?
I think. That's it.
But child had a happy ending. That is one thing.
Yes, sir.
Yeah. Though the discussion didn't go properly, child had a good happy ending.
Yes, sir. Child recovered. That's why we are very happy.
Yeah.
That's another reason to present this case also, because with such an encephalopathy and 2 times jaundice relapsing, recovered.
It is a mixture of things that must have caused. One, valproate must have precipitated something.
Yes,
and some other underlying condition is there.
Yeah, yes, sir.
So that's why after discontinuing,
I think we have to follow this case and once again reinvestigate.
Yeah.
So that we can clinch out the.
Any other causes for cerebral edema you thought of? Because papilledema is there.
Yes, sir.
Yes, sir.
Amma, CT was done, Amma, CT.
Yes, sir. CT was done. It was suggestive of cerebral edema.
Cerebral edema. Okay, they did not give anything.
Okay. And you treated with mannitol or 3% saline?
So we gave him mannitol, sir.
Mannitol. Okay.
He received N-acetylcysteine, rifaximin syrup, lactulose, sir.
Okay.
And vitamin K was given. F50 transfusion, sir. because after admission also he had blood in stools, sir, over 3 to 4 days. And
Any
for
upper
this
GI
time-
was done?
yes, sir.
Upper GI.
No, sir, that was not.
Sir, ultrasound abdomen, the portal pressures, what they have mentioned was normal. So
Normal, sir.
that was the reason that varices was not thought about. And there was no bleeding in the vomitings, or there was no history of such presentation. So
Melina is there, no? Melina.
Melina was there, sir.
Melina is upper GI bleed only, no?
Yes, sir.
Yes, sir. Yes, sir. Melina was initially there, so we were not very clear about this Melina presentation also. Dark colored stools, which was exactly what you mentioned, like a tarry stool.
Yeah, yeah.
So yes, sir. Sir, if it was there, it would have been a different presentation, and the case would have been in a different scenario.
Right.
So probability of a CNS cause, what Vijay Kumar sir still said, there is a possibility that some hidden history definitely happens at times, sir. Because unless there is a familial history of seizures, or the child presenting suddenly with a seizure and then for 3 years after treatment that subsided, it will usually not happen.
So, what is the provision of these parents? Any chemicals involved or?
No, sir, they were not involved. Even I asked for that. Even I asked, because I remember that previously once I happened to come across such cases where the parents were the road laying workers, sir. They use that coal tar and all.
Yeah. Dr. Subramanian sir, anything you want to tell?
Sir, good morning, sir. Very nice discussion and very nice moderation by you. But point here, what was the cause of hypotension in this case? What is the cause? It has been ascribed for the child to have hypotension, because child actually presented with symptoms of raised intracranial tension with papal edema. And there is a pupil dilatation also. It is obviously a case of possible metabolic encephalopathy secondary to liver cell failure. And the child had jaundice before also. It signifies child had a chronic, either recurrent or a chronic problem, which is causing a hepatic insult. And child now presented with acute crisis, like hepatocellular failure. Of course, fortunately, child has made a recovery. It appears it is obviously a metabolic cause, because of which the child has made a recovery. Then what is the cause of hypotension?
So intake is not there, and moreover GI bleed is there. I think that must have resulted it.
Yes, sir.
As soon as they see jaundice, they stop everything.
Usually we come across children with raised intracranial tension, hypertension, sir.
Because according to the history also, hypoglycemia is there.
Hypoglycemia is there, sir.
Yeah, that is mentioned.
So that could be the cause for hypotension also.
Yeah, everything together.
So
myocardial function also, is it?
But our friends,
good morning, everyone.
Our friends have diagnosed it is positive autoimmune hepatitis because antibody was positive.
Yeah.
But such a case usually, I think we will have the telltale evidence of chronic process, chronicity of the process. So some clinical evidence should be there. Say, for example, clubbing or palmar erythema or some chronic liver cell failure evidence should have been there. Because child accused the history of jaundice before also. That is my doubt. How to explain the absence of signs of chronicity?
The thing is, sir, he has stopped sodium valproate around 6 months ago, and that doesn't cause jaundice. Probably there may be some damage by valproate hepatitis. Other thing is jaundice 3 months ago. Now that has subsided both times. It looked like a relapsing hepatitis rather than the major gross damage. Other thing is he was in shock. Probably that shock is more overwhelming than the raised ICT. And other thing is COVID positivity. I think it has been mixed up. So we can consider, we can explain the shock with this, the hypotension with this shock. What I feel is that.
What I thought, sir, I thought this is
also was done. Hepatitis C. C was done. C.
Yes, sir. Yes, sir.
Negative, sir. Hepatitis C.
All hepatitis profile was negative.
Okay.
Sir, I do not conclude. It is open for discussion. But what I thought is this is a case of acute liver cell failure with hepatic encephalopathy, and
Yes.
with good supportive care, the child has come out of this episode.
Yes, sir.
And then there is a doubt about exact diagnosis of the acute liver cell failure and hepatic encephalopathy.
Yes.
So one issue here is, in the next visit, what are the tests that are to be done to prove this episode, and how long we give steroid. These two are the issues. So the supportive care is good enough for the improvement, for the clinical improvement.
Future investigations pending in this child is, one, we would like to perform a cholangiogram to complete our diagnosis whether it is cholangitis or not, sir, and also liver biopsy to be considered in children with AMA-M2 positivity is given, sir. Steroids can be given up to a period of 3 months, and then the child should be observed for any relapsing episodes during the
Disturbance, background disturbance. Yes. And regarding chronic and acute also, between adult liver disease and child disease, they have very different things. Acute, for adults, it is acute is less than 2 weeks, 2 to 6 is subacute, and then chronic more than 6 months. But
Yes.
then for any liver disease in children, this 6 months is not there, and
Yes.
clinical signs so need not be there. So it's 2 to 3 months, and then maybe biopsy is indicated at this point for this case.
Sir, in the next visit, I think we want to do biopsy, immunoglobulin status, and also once again repeat the other LFTs so that we can clinch, and we'll take the opinion of the even hepatologist also. So we could not send him in this COVID season. Furthermore, and we'll repeat the antibodies for mitochondrial. Mitochondrial antibodies also positive.
Yes, sir. I think.
Sir, any suggestions regarding the further investigations?
Sir, any amino acidogram or such things also you can send, sir. Serum and urinary amino acids.
Amino aciduria, okay, sir.
Yeah.
Angiogram, all these things we want to plan. And
his metabolic profile is negative, sir, already.
Yeah.
Normal?
Already his metabolic profile is negative, sir. Urine metabolic.
What are the things that were done?
Amino acidurias and reducing substances. It was ruled out.
It's for fructose intolerance and.
Yes, sir.
Okay. Because hypoglycemia can come in both the galactosemia and fructose intolerance.
Okay.
And of course, IE was tested, though there is no cataract.
Yes.
Alpha 1 antitrypsin, we don't know. They are very rare in these parts of the world.
Those are all because child was normal till 4.5 years. That also.
Dr. Alamelu says porphyria to be thought of.
Yeah.
Yes, sir.
Sir,
Sir, just one point at this time, sir. As far as the steroid dose is concerned, it can be, once the inflammation of the liver comes down, low dose at say about 0.3 to 0.5 milligrams per kg over per 24 hours. It can be continued over 2 to 4 months, and serial follow-up of this patient should be done with as you said, either with the enzyme profiles, and also the immunological profile should be done for this case over a period of more than 2 to 4 months.
I think even liver biopsies.
Liver biopsy
is planned.
Yeah. We'll plan liver biopsy, cholangiogram, immunoglobulins.
Cholangiogram, I don't think it is required.
Sir.
No? There is no obstruction anywhere.
No obstructions.
No obstruction. Alkaline phosphatase, I think it didn't raise.
A bit raised.
There is no fever.
No fever.
Ultrasound must have shown the intrahepatic, the biliary, the paucity,
It
all
is
those
normal,
things.
sir.
Yeah, there is no, the faces, all those things that doesn't suggest any problem, isn't it? Like illegally something like that, no?
No.
Thing is there. So cholangiogram is not required.
Okay. Sir, I thought Dr. Juveri has done quite well, sir.
Yeah.
Thank you.
With whatever workup is done, and congratulations to her. And sir, over to Tilak, sir. Thank you, sir.
Right, sir. So well discussed. And Dr. Vijay and Dr. George, Dr. Rajay Mohan. So you have assisted the discussion well.
Thank you.
Dr. Juvair has presented well.
Thank you.
And a little more, say, because this is a difficult case. Actually, it's a PICU case. Is it not? So PICU case, it is difficult to discuss like an ambulatory case.
Yes.
So the list of things under the clinical science, all those things will be difficult and subjective, is it not?
Yes.
Did you see the fundus examination yourself? Or,
No, sir, we call the ophthalmology PG only.
at least you have seen through the scope?
Yes, sir.
Huh? You should grab the opportunity to see.
Yes, sir, we do, sir. We take their
Don't
assistance.
hand over everything to others and say, take their inference. Huh?
No, sir.
Do it yourselves. At least when she brought the ophthalmoscope, we should have peeped into the fundus.
We saw, sir. Yes, sir.
Very good.
They show us, sir, when they.
COVID positive child and fundoscopy face to face.
The person, I feel COVID has nothing to do here.
Yes.
It is positive maybe, but I feel COVID has nothing to do. Valproate has something to do. And over that, there is some underlying the hepatic disease may be there, which we have to detect.
Yes.
But fortunately, the child came out from a very bad state.
Yes.
And for that management, I congratulate you.
Thank you.
Right.
So all the team in Gandhi PICU, they were very much equipped because of this COVID season. They have provided everything, sir.
Yeah.
I got oxygen and almost ventilators for 60 to 80 beds, sir. 80 beds are equipped PICU beds.
Yes.
So everyone is now became intensivists. rather than good clinicians. So intensivists, Gandhi has made now intensive hospital. They have provided 2,000 beds for oxygen, sir. With oxygen and everything. Right. So more concentration for intensive care. So they are vigorous in treating the child. So I feel that because this is a COVID season and it was positive, yes, for the sake of the PGs, we said MISC also we have to consider. And initially we could not come to a conclusion. So what we thought is, yes, a second possibility, third possibility, Wilson's and metabolic we entertained. And finally infective we could not say because at any time in his career there is no fever. And he was not toxic, but still anictoric can be considered. And finally, autoantibodies, mitochondrial antibodies came positive. We thought still it can be mitochondrial antibody, some race-like picture. So
and this child has siblings, no?
Yes, sir. One small daughter. Younger siblings, sir. Female child.
Younger sister. Okay. Still a lot of time is there for her.
6 months old.
Right.
So Bhaskar bhai?
Yes, sir. Sir, even me, I had little confusion when you had put that Missy on first number in differential diagnosis. Yeah. Probably because Gandhi means COVID, COVID means Gandhi.
Child was positive.
But Missy, little confusion about whether it is really Missy or not.
And there is multi-system involvement, positive, child is in shock. So we want to be nearest to diagnose because we are in confusion initially.
Yeah. If it is over, experts.
Yeah, if you permit me, I'll leave. Huh?
Thank you. Thank you, Dr. Judge, sir. Thank you very much for forwarding a very interesting case.
Thank you.
Thank you, sir. Over to you. Dr. Bhaskar and Dr. Sri Krishna.
Thank you, sir. It was really an excellent case and a good discussion. Precise, not a very long discussion, but useful discussion. This we were expecting from both the experts, Dr. Vijay Kumar and Dr. Tilak Chandrapal sir. Thank you, Dr. Suchitra. Thank you, Dr. Ajay Mohan, and all the participants. Juvera, you are the luckiest person. You had passed through the examination, that too from experts like Dr. Tilak Chandrapal sir.
Thank you, sir.
Dr.
Thank
Vijay
you for.
Kumar.
Thank you for giving the opportunity, sir. I thank Dr. Suchitra ma'am, Dr. George sir, and Ajay Mohan sir for guiding me.
Dr. Suchitra, do you have any comments about this case? Concluding comments, because you had worked up with her. Dr. Suchitra, are you available there? Dr. Suchitra? Okay. Dr. RSV, if we have Dr. Vamshi, our treasurer, I request him to say a word of thanks.
Hello, sir. I was unable to unmute.
Yeah, please,
yeah. Now, yes, sir. Yes, I was unable to unmute just now. RSV allowed me. Yes, sir. So, sir, the criteria why we have taken, we have seen many cases, but why we wanted this to be presented and discussed is because we have seniors as experts, and they will give their inputs and better. See, at times we reach to one point wherein we look for our seniors to be really coming into picture. Always an evolving disease need to be followed up closely, and of course, acute management was well managed. That was the reason child is out. So there are much possibilities of MELAS also maybe evolving because child didn't present with stroke or child didn't have another presentations. But mitochondrial encephalopathies, yes, it is an evolving kind of presentation. COVID is one thing which is entered into all arenas, be it respiratory, be it GI, be it renal. Or so we had an opportunity to see all chronic conditions presenting with having a COVID in them. So COVID series, definitely we will look forward for that, sir. But here, taken point is that valparin for every purpose should not be used even for simple febrile seizures as a take-home message. And for practitioners, what we usually see is, sir, as the case is taken up to them. So follow up for the liver enzymes, because if an institute, they follow up all these investigations like getting an EEG done or evaluating for the liver enzymes or following it up regularly. But when the same child goes outside with the same presentation, we need to be following it carefully and refer to the better place. That was only my concern. Thank you very much, Bhaskar sir, for giving us an opportunity.
Yeah, thank you, Dr. Suchitra. The keyword which was told by Dr. Vijay Kumar was, it's not only for PGs or practicing pediatricians like me, it's a knowledge sharing between the experts and probably students, learners, and practicing pediatricians. Really, we appreciate the humbleness of Dr. Suchitra, looking forward for expert advisors. That's her real greatness. Thank you, Dr. Suchitra. And Dr. RSV, Dr. Vamshi is there? Yeah, if not, once again, I sincerely thank you all. Please be with us, participate in our academic programs and encourage us. And I request our seniors, experts to guide us in making our programs in a better way. Thank you all once again. Namaste.
Thank you, sir.
Thank you.